On behalf of the Chilean Society for Reproductive Medicine, I wish to thank IFFS for the opportunity to present our society and some of the reproductive realities in my country. Our society was founded in 1962 as a Chilean fertility society and changed its name to the actual name in 2014. It has an average of 100 active members, including mostly obstetricians, gynecologists, andrologists, biologists, embryologists, and also nurses and psychologists working associated to reproductive centers. Its board is elected every 2 years by the General Assembly, consisting of a president, who today is Alejandro Mansur, and 10 members representing the main fertility centers in the country. And in conjunction with the Ministry of Health, we have developed guidelines for fertility treatment at different healthcare settings, primary, tertiary, secondary healthcare settings. And we do also advocacy for reproductive rights, together with patients' organizations and other societies. Today, Chile is writing a new constitution, and the body writing the constitution have been elected, the 150 members elected publicly. So the society is very much involved in the writing of this constitution, and that's why advocacy is very important at this moment. But let's review for a moment the national health structure for health in general, but also for fertility care. We have a very strong primary healthcare network, which is completely free. It covers 100% of the population. And in terms of fertility care, its role is to educate, prevent, diagnose, but also provide simple treatments, because it's equipped with a midwife and a general practitioner. Most of the centers are equipped. They also have ultrasound because of obstetric care. But then we have a secondary healthcare center, which is in the midline between primary and tertiary in terms of equipment. They have laboratory facilities, they have images, they have a permanent gynecologist at least 3 times a week, and a permanent midwife. We can do semen analysis there, and we can also perform insemination and etc. And then we have the tertiary healthcare center, the hospitals, and the network with private, most of them private centers providing assisted reproductive technology. Now, the main problem in the past is that most of the patients seen the primary healthcare were referred directly to tertiary healthcare, where they have long waiting lists, where it's far from where they live, so they have to deal with a number of complexities in their homes in order to be seen at the tertiary healthcare. And for that purpose, our society, together with the Ministry of Health, developed guidelines for fertility care and infertility treatment at primary, secondary, and tertiary healthcare. And these guidelines were signed and approved by the Ministry of Health in December 2015 and became operative in 2016 and onwards. It's not proved easy to implement because, of course, the pressure of patients in the primary healthcare is large. But we have been training midwives and general practitioners on how to deal with infertility at those levels, and it's proved to be progressively useful. But Chile faces 2 major reproductive difficulties. One is the progressive drop in the total fertility rate and delayed motherhood. And this is not common for only for Chile, but our reality is quite particular. Chile had a total fertility rate of 2.5 in 1992. And today, our total fertility rate is only 1.56. It's the lowest in the Americas by far. Uruguay and Cuba were the lowest one until recently, but now our population does not want to have children. Furthermore, 16% of the babies born in Chile in 2019 were born from migrants, which is fantastic in terms of cultural diversity, but they're not living very happy lives in our country, and the education of their children is also very difficult. So in fact, if we look at the future, this will be a major problem. But the problem is not only the lowering the number of births per 1,000 women in Chile, but the delay in motherhood. And in the late 70s and early 80s, the majority of births, these are all births, not first birth, the majority of births took place in women between 20 and 24, while the majority of births today take place in women 30 and 34, bringing more comorbidity, decreasing fecundity, etc., with all the problems that we all know. And this is not a problem of the general population. If we look at the age distribution of women treated in IVF in my country, in the mid-90s and the late 90s, 50 to 60% of women were young women under the age of 34 or under. And only 10%, or mostly 12, 13% were 40 years or older. Today, however, only 27% of women are young women who treated, and 30% of women are 40 years or older. So 72% of the women we treat in IVF are 35 years and older, and not said here, 53% are 38 years and older. And if we look at the consequences of this, these are the fresh and cumulative birth rate in Chile between the year 2016 and 18. And if we see here in the blue, we have the fresh delivery rates, and in red, we have the cumulative delivery rate, which is quite decent, I think, for young women, almost 60% of cumulative birth rate after one single aspiration cycle. So aspiration plus all the embryos that they could preserve, 59% in very young, these numbers here are very small, in very young women. But as I mentioned before, 53% of our patients are 58 years and older. And here we can say that with one cycle, either out-of-pocket funded or state funded, with one cycle, 2/3 of women will remain childless. And this is a difficult reality to deal with. One of the consequences of this is oocyte reproductive donation, which we reported first in 1996. But look how it has increased. And this is in relationship with the aging of women before they start motherhood. So are we prepared to deal with this rapid change in reproductive behavior? I would say we are not prepared, because we have which is a second problem, restricted access to assisted reproductive technology, to technology altogether. And this restriction is due to economic reasons and due to gender and family structure. So the small help that the state provides to assisted reproductive technology is restricted to heterosexual couples. So it does not include single women by choice. It does not include same-sex couples, and it does not include oocyte donation. As I mentioned before, it's becoming very prevalent. And if we look globally at the help of our state, we see in blue, it's the proportion of women out-of-pocket funded, IVF out-of-pocket funded, which is 90% almost, and 10% is only receiving state help. Since 2019, there is a new program whereby the state provides half of the costs, the fixed cost, and the patient provides the other half. And so this should increase a little bit, but again, those are not, do not cover single women and do not cover same-sex couples by choice. So these are one of the things that we want to ensure in the new constitution. In terms of art utilization globally in Latin America, Uruguay and Argentina have the highest because they have laws providing universal care and they are increasing their utilization. Chile has 323 cycles per million inhabitants, which is not that bad if we look at the rest of Latin America. But if we compare this with the rest of the world, these 300 cycles compare with 5,500 in Israel, Japan, Malaysia, Australia, Sweden, France, Germany, etc. The case of the US will be discussed by them, I would imagine. But so utilization is extremely low, and the reason for this is economical reasons. So what we see as challenges for the future, now that we are writing the new constitution, is to set up the right to found a family as a human right, respecting the right to reproductive autonomy on the one hand, and the right to receive information and equitable access to technological advances in infertility treatments. To ensure procreative rights to all persons, irrespective of the type of family they wish to build. And third, to have progressively provide equalitarian access to modern and safe fertility treatments to those with economic restrictions. So in this way, I stop my presentation and I'm open to any questions about our reality. And thank you very much for this opportunity.